Great, thank you so much. We didn't realize we would have nice background music for, this is almost the remix of my presentation. I'm really excited to be here today, and I'd love to kind of have this stimulate a conversation of what we're observing with regards to racial disparities. First, I want to say I have no conflicts of interest or any industry affiliations. This is solely from the research work that we've been doing at the University of Pennsylvania. So I want to start off with a definition just to get us all in the right mind frame. So we've been talking here about disparities, and I'll add another definition to it. So I'm going to define disparities as the differences in health and healthcare between groups that cannot be simply explained by the variations in need, preference, or treatment. And there's two types of disparities I think we could unpack it a bit. So one is we could think about health disparities, which Dr. Nesbitt has really adequately described here, which is high rates of illness, injury, disability, or mortality that happen in certain populations. The other way to also think about this is healthcare disparities. So it's essentially what happens to patients of different races or different groups as they engage and interact with the healthcare system. And so we can think about this in worse insurance coverage, access and use of care, and I'm going to really focus in on quality of care here. And so I'll highlight here what I think is really the core debate, or really the core concept that I think about this. So if two men or women equal in every way, but were of a different race, walked out of the hospital having been treated for the same exact disease, and one experiences a worse quality of care or has a worse outcome, what do we do? Should we do something about it? And how do we respond to that? And I think to set the stage even more, this is a really complicated topic because there are so many different forces that are affecting different disparities between races or different groups of individuals. So one is certainly the environment or where they live. The other one is hospitals and how they're treating patients. And then finally, we can't ignore individual choices or how patients are addressing their own behaviors. And all of these feed into this mechanism of what we're observing as patient outcomes, particularly when we're thinking about patient quality. I thought since we're in DC, we should show some maps. So this is a report out by the Robert Wood Johnson Foundation a couple of years ago. And I think what it highlights is it matters where we live. And so what they did was they essentially looked at different life expectancies based on subway networks or highway networks. And basically showing that just as you travel down the road, the neighborhood that you drive past can start to expect a different life expectancy. And so here you can see in the heart of DC, that the life expectancy is 77 years, but as you go into the more wealthier suburbs or neighborhoods, you start to have a longer life expectancy. I think when you look at New Orleans, you can start to even see a deeper contrast. So this is actually a zoomed up map, and this is just traveling down like half a mile to a mile. And so you can go from the outlying areas where you can be expected to live 80 years or 75 years, and if you go into the heart near the French Quarter, your life expectancy then becomes 55 years. And so what explains these kind of different variations? What's happening in these environments? What kind of healthcare access do they have? I think these are all critical questions as we try to think about how to narrow this gap. And what I want to say, and quite simply, is that healthcare disparities are real. And I'm going to go through a couple illustrative examples of one way in which we've been measuring and observing this. First of all, I think one thing we need to really think about is we measure a number of different outcomes in healthcare. And what we're starting to see is that we can see that there are differences between these racial groups. And so I think it's important to look at these and to be able to measure these. So this is a diagram that essentially shows how different racial groups compare to whites. And so across a number of different measures, you can see here, for example, if you work your way from left to right, Asian Americans, for about 25 out of these 29 measures, actually have better outcomes. But as you look at blacks or Hispanics, the picture starts to become a little bit more mixed and potentially even more depressing as you kind of see that there are significant differences, particularly between blacks and whites in their healthcare outcomes. The second part to this is we've long now observed that there are many unintended consequences when we just think about value. And so today's conference is really talking about the value of care. And we're really moved. This has become a really popular term to talk about as value. In the healthcare industry and the healthcare delivery side of things, we think about quality in particular as the value of care. So basically, are you getting good quality care for the price that you're paying for that care? And we have tried to do this by monitoring this more. So we've observed this in report cards, hospital quality measures as we're comparing them, pay-for-performance measure, value-based payment modifiers. And one of the unifying themes here is that is either that patients or, not patients, providers or healthcare systems may actually be doing this term what we're calling cherry picking. And so what you want to avoid essentially is that you put in a quality measure, they know that certain racial groups or certain groups of people aren't going to perform better, so we're just going to try to maybe not treat them or not put them on a certain care pathway because we know that they're actually going to change our quality output when we're reporting it to the insurance company or to Medicare or to CMS at the end of the day. The second part to this too is that I think we have a lot of well-intentioned efforts too, but we're having these unintended consequences where we're trying to kind of move in a better direction, but we may start to observe that they're actually widening the gaps between different racial groups. I'm going to show a series of graphs to show actually what might be happening, because I think the picture here is actually can be very complicated here. So on the left side is actually a group that's doing worse. For all intents and purposes, I'm going to talk really about black and white disparities. So the left column is going to be black patients. The right column is going to be white patients. And you can imagine that we're trying to achieve the very top bar for both groups at the end of the day. And this is the current gap. Let's say then we implement a quality improvement effort kind of nationally as a policy. And so one thing that might happen is actually both groups improve, and both groups improve equally here, okay? But then at the end of the result, you still have the same gap there. Maybe this is okay, you know? Maybe we've actually improved things across the board, and maybe we're willing to accept that gap. One thing we're probably not willing to accept when we're paying for quality improvements is neither group improves, and so maybe that's not really where we want to head in this direction. The other one might be a little different. Let's say we do this quality improvement thing, and both of them just seem to actually do worse. But we actually get the white population actually tends to have a worse outcome there, and the gap actually closes. And so, you know, it's important, I think this, as we're going along the steps, it's important not to only measure the gap, but what's happening in both groups as we're going along the way. And then finally, what we definitely also don't want is that the worse off group does a lot worse as both are kind of declining in quality. What we're probably more commonly seeing, though, is that we're getting disproportionate gains. Okay? So one scenario may be that the worse off group is actually improving more so than the group that was doing off better before. What we're oftentimes seeing, though, is that the gains are actually being seen by the group that was already doing well to begin with. And now I will actually say one caveat or one asterisk behind this is it's a little unclear in time whether or not the differences even out over time. So you can imagine that it takes a little bit longer for minority groups or groups that are doing worse off in the beginning to take their time to get there. So I think not only monitoring this change, but then also monitoring it over time is a really important key point here. So I'm going to highlight this through the readmissions program. So how many in the room have heard of the readmissions program here? So I'll quickly just put it in one line. We basically are penalizing hospitals for higher than expected readmissions. And so this came with the ACA. It finally got enforced about 2 or 3 years later in October of 2012. And it's a significant ding. So when you think about hospital margins existing anywhere between 1% and maybe 2%, this is basically saying, you know what, if you were in the bottom rung of readmissions, we're going to penalize you 1% to 3%, not just for the diseases that we're targeting, but for all Medicare readmissions. And so they focused in on 3 of them that they thought were easily kind of low-hanging fruit to target. So pneumonia, heart failure, heart attacks. And over time, we've amassed an enormous amount of evidence of kind of what's been happening. So one, we know that safety net hospitals are being penalized much more often. We know that black patients are more often seeking care at safety net hospitals, and that black patients at baseline already have higher readmissions rates. So you can imagine here that basically what's happening is that these safety net hospitals are continuing to get dinged over and over again, and that black patients may actually be going to hospitals that are getting less and less revenue over time. And so you can imagine now a storyline that might play itself out, that the quality in these hospitals may be playing itself out. We have tried to correct this, and we've been talking a lot about risk adjustments. There's been some risk adjustment talk about the last week or so, which I can delve in the panel here. But there is evidence that even just risk adjusting for the neighborhood or some of their demographic features, that's not really going to lessen the penalties. And so what we're unclear, though, is at the racial level, are we getting disparities? what's been happening at the safety net hospitals, and what about non-targeted conditions. And so I'm going to walk you through this here. So this is actually a chart, I guess I won't figure out the pointer in the dues time here, but what you can actually see here is these are little small changes that you can start to observe between the ACA and the HRRP actually coming into effect. And you actually can start to see disparities actually start to narrow between black patients in the orange and white patients in the black here. And then it starts to stabilize out after HRRP. But the story actually becomes more interesting when you start looking within hospitals here. So if you look at safety net hospitals, they had a huge closure in the gap because of actually they just started to gear up for all these changes that were happening. But then when they started getting penalized in the years afterwards, they weren't able to make much more of a dent. Non-safety net hospitals were also kind of starting to gear up, started to have this narrowing, and again, parallel. But I think what's actually even more interesting, if you look at the non-target conditions, which is 80% of all the conditions that are out of the hospital, they basically close the gap within safety net hospitals, but then afterwards, they're basically starting to widen again. Now, remember my old story. I basically told you that they're actually getting penalized more and more and more, right? So despite the fact that they've actually done significant advances in closing the gap, we actually may start to see a storyline that over time, we're gonna start to see actually a re-widening of these disparities within safety net hospitals. And then finally, you can look at it from these non-targeted conditions here. So we can unpackage this a little bit more in the panel here. The other part to this too is what's the role of the hospital in really dealing with these challenges? First of all, we all know that social determinants can worsen health and readmission rates. And some hospitals actually started to address the social determinants of health over time to really address some of these community needs. However, it's really unclear whether addressing these community needs actually lowers readmission rates at the hospital level. So we decided to look at this because hospitals actually have been reporting all their community benefit spending through their tax form 990. So all of us fill out our 1040. This is the equivalent for the hospital to like file your taxes here. And this is a huge break. So if they qualify for nonprofit statuses, nonprofit hospitals across the country get $25 billion in tax breaks. And they basically have to prove this through these 990 forms and these Schedule A's. And then many of you are probably a part of these community health needs assessments that happen to kind of say, what does our community need? And so we looked at this, and so we did a breakdown actually of every single way that hospitals have been spending their community benefit. So if you look across the board at all total community benefits here, there's not really much of a difference in readmission rates as you kind of walk through each of those bars. And so low means low spending in total community benefits, high means high spending in community benefits, and then basically the middle line here is changes in readmission rates. When they spend in healthcare related, so we talked about charity care before, there's also still not much of a difference. Interestingly, when you look at hospitals that actually spend much more money on community spending or community needs, they actually see a significant ROI or return on investment essentially on lower readmission rates that are happening within their communities. And so we're starting to see some early signals here that hospitals that actually invest in the communities are actually getting some downstream effects that are feeding back into their bottom line or these readmission penalties at the end of the day. And so finally, I'll close on this path forward. I've written about this and thought about this quite a bit over the last couple of years. One of the challenges here is really saying that our actuarial adjustments really just are probably not enough. And we really probably need to start thinking more and more about disparities as actually a goal that we value in healthcare, and that we should be monitoring that, and perhaps we should be thinking about what are the downstream effects of our payment reforms to get us there. And in essence, really, if we can agree as a community that equality or better healthcare across racial groups is a goal that it's worth paying for. And then finally, I think there's a lot of kind of insights here to really start to think about public health-minded approaches towards improving healthcare outcomes, not just health outcomes at the end of the day. So, great. That's all on there.